Alcohol. It's pretty much everywhere in our culture, right? It's at celebrations, social get-togethers, even just for a quiet night at home. And because it's so common, it's really easy to forget just how powerful it can be. For a lot of people, that line between just casual use and a real clinical disorder can get, well, dangerously blurry.
So that brings us to the big question for this whole explainer. When exactly does drinking cross that line? When does it stop being a social habit and become an actual medical diagnosis? Well, it happens when the substance starts calling the shots instead of the other way around.
And clinically, that diagnosis is called alcohol use disorder, or AUD for short. You can really break it down into 4 main features. First, a loss of control over your drinking. Second, a really powerful craving for it. Third, continuing to use it even when it's causing real harm. And fourth, physical dependence, which covers things like tolerance and withdrawal.
All right, so here's our roadmap. We're going to start with how AOU is officially diagnosed. Then, we'll dive into the science of how it hijacks the brain's reward system. After that, we'll walk through the withdrawal timeline, which can be really dangerous. Then we'll zoom out and see the damage it can do to the entire body. And finally, we'll wrap up with how it's actually managed by healthcare professionals.
So how does a doctor actually figure out if someone has alcohol use disorder? It's not just a hunch. There's a very specific set of criteria they use.
The diagnosis actually comes from the DSM-5, which is kind of the official handbook for mental health disorders. It lays out 11 possible symptoms. If a person has at least 2 of those symptoms pop up within a 12-month period, then a diagnosis can be made. And you can see it's a spectrum. It can be mild, moderate, or severe, all depending on just how many of those symptoms are present.
Okay, now let's get into the core science of it all. If you really want to understand why AUD is so incredibly powerful, you have to look at what's happening chemically inside the brain. This is where the whole cycle of addiction really takes root.
Okay, I want you to think of your brain as having a gas pedal and a brake pedal. They work together to keep everything running in balance. The main brake is a neurotransmitter called GABA. It's what calms things down. And the main gas pedal is glutamate. It's what amps things up. Alcohol comes in and just completely messes with both of them.
So when someone takes a drink, alcohol immediately slams on the brain's brakes by boosting GABA. That's why people feel relaxed, kind of sedated. At the same exact time, it takes the foot off the gas by blocking glutamate. But, and this is the absolute key, a super high yield point, alcohol also floods the brain's reward pathway with dopamine. And that surge of pleasure is what makes the brain say, wow, that was good, let's do that again. That's the feeling that drives the craving.
But here's the thing about the brain. It is incredibly adaptive. If you keep flooding it with something that's constantly hitting the brakes and easing up on the gas, it's not just going to take it lying down. It starts to fight back to get things back to normal.
So over time, the GABA receptors, our brakes, they become less and less sensitive. You can think of them as just wearing out. And to make up for that, the brain starts installing more glutamate receptors. The gas pedal basically gets stuck to the floor. This creates 2 huge problems. First, tolerance, which means you need more and more alcohol to get that same relaxed feeling. And second, it leaves the brain in a constant state of hyperexcitability. And that state of hyperexcitability is precisely why withdrawal is so incredibly dangerous. When you suddenly take the alcohol away, that brain, which has been fighting so hard to stay revved up, is left with a gas pedal that's stuck down and brakes that don't work anymore. The whole system goes into crisis mode.
And this timeline really shows you how fast that crisis can escalate. It can start with tremors and anxiety in just the first 6 to 12 hours. Within a day, you can get hallucinations. Then, that brain hyperexcitability can spill over and trigger seizures. And finally, after about 2 days, the most severe stage can hit, delirium tremens.
And let's be crystal clear about this. It's a high yield point for a reason. Delirium tremens, or DTs, is a full-blown medical emergency. We're talking severe confusion and a completely unstable autonomic system, which affects your heart rate, your blood pressure, everything. It has a high mortality rate if it's not treated, so it requires immediate medical help.
So we've just seen the acute crisis of withdrawal. But the damage from chronic alcohol use, well, it goes far beyond the brain. This long-term fallout is systemic, meaning it affects pretty much the entire body. Sticking with the nervous system for a minute, one of the worst complications is Wernicke-Korsakoff syndrome. This is caused by a serious deficiency in thiamine, which is vitamin B1. It has a classic triad of symptoms: confusion, an unsteady walk called ataxia, and weakness in the eye muscles. If you don't treat it fast, it can progress to Korsakoff syndrome, which causes profound and often irreversible memory loss. And the damage just keeps going. Alcohol really is a multi-system toxin.
It can lead to cirrhosis of the liver, weaken the heart muscle, inflame the pancreas, tear up the stomach lining, and it can even affect your red blood cells, making them get abnormally large. That's a condition called macrocytosis.
So, given all this potential for widespread damage, what's the clinical response? How do doctors and nurses actually diagnose, manage, and treat alcohol use disorder?
Well, even though the official diagnosis is based on those DSM-5 symptoms, there are some lab tests that can give really strong supporting evidence of chronic heavy drinking. These include an elevated GGT, which is a sensitive liver enzyme, that macrocytosis, the large red blood cells that we just mentioned, and a really specific pattern in the other liver enzymes.
And here is a classic exam point. You'll see this one again. In alcoholic liver disease, two liver enzymes, AST and ALT, are both elevated. But the real giveaway is the ratio between them. When the AST is more than double the ALT, that is highly suggestive that alcohol is what's causing the liver damage.
Now for a clinical tip that is so important it can literally save a patient's brain function. Since chronic alcohol use causes that thiamine deficiency, if you give a patient glucose, like in a standard IV drip, without giving thiamine first, you can actually burn up the body's last little bit of thiamine and push them right into Wernicke's. So the golden rule is always thiamine before glucose.
The overall treatment approach really breaks down into two main parts. Step 1, you have to safely manage that acute withdrawal. Remember that hyperexcitable brain? We use benzodiazepines to basically calm the nervous system down and prevent those dangerous seizures. Then, once the patient is stable, the focus shifts to step 2, promoting long-term abstinence, which is usually a combination of therapy and medication. And there are several key medications that can help support that long-term recovery. Naltrexone works by dialing down the cravings and the rewarding feeling you get from alcohol. Acamprosate helps to restabilize those GABA and glutamate systems we talked about at the beginning. And then there's disulfiram, which is more of a deterrent. It makes you feel really sick if you drink alcohol. Okay, let's do a quick recap of the absolute most critical takeaways. First, and maybe most importantly, AUD is a chronic brain disorder. It's not a moral failing. Second, withdrawal can be life-threatening and DTs are a true emergency. Third, that golden clinical rule, always give thiamine before glucose. And finally, remember that treatment is a two-step process. Manage the acute withdrawal first, then provide long-term support.
So, we've seen that alcohol use disorder is a complex but understandable disease. It has clear biological roots, and there are established, effective treatments. The good news is it's treatable, which really leaves us with one final, crucial question to think about. Knowing all of this, what do you think is the single biggest barrier that keeps people from getting the help they need?